Hi, sports medicine students, and welcome back. This is lesson 4 of the knee notes. We're going to start with a review, with some review questions to see what you know here. Question number 1, what are the 4 bones that make up the knee joint? The 4 bones that make up the knee joint. The 4 bones that make up the knee joint are the femur, your upper leg, your tibia of your lower leg, your patella, which is the sesamoid bone of your kneecap, and the fibula are the 4 bones that make up the knee joint. Question number 2. The patella rides in the blank of the distal end of the femur. What is that called? It's a groove. What is that groove on the femur called? Hopefully you knew it, the trochlear groove. Question number 3. The shock absorbers in the knees are called what? You have a medial and a lateral in both knees. You have 4 of these. What are the shock absorbers called? The meniscus or menisci would be plural. All right, that's question number 3. Question number 4 is going to be on our next slide. What are the 4 main ligaments of the knee that we talked about? What are the 4 main ligaments of the knee? There's 4 of them that we talked about. In our notes, we talked about the ACL and the PCL, which ACL stands for anterior cruciate ligament. PCL stands for posterior cruciate ligament. And then we had the medial collateral ligament, or MCL. And then we have the lateral collateral ligament, or the LCL. So those are the 4 main ligaments of the knee: ACL, PCL, MCL, and LCL. Question number 5. What is injured when we talk about Donohue's triad? O'Donoghue's triad, terrible triad. There's 3 things. O'Donoghue's terrible triad is an ACL tear, a meniscus tear, and an MCL tear, are the 3 things of O'Donoghue's terrible triad. Question number 6, and the last review question we'll go over today. An increased Q angle we talked about in some athletes could lead to a greater risk of what injury? A greater Q angle. We talked about this, maybe wider hips that comes in, kind of knock-kneed, would be a wide Q angle. An ACL tear is the answer to that question. All right, hopefully you knew some of those, and we'll get started with today's information. The first thing is patella dislocation. It's not difficult to pop patella back in place by a certified athletic trainer. What they do is they extend the leg fully and put medial force, if needed, until the patella pops back into place. You guys, a famous patella dislocation that happened just in the past year would be Patrick Mahomes' patella. And there's a picture of a doctor putting...
And it's like they almost popped that.
I'm going to watch that again.
And it's like they almost popped that. And it's like they almost popped
that. Patella dislocation. Also, a shattered patella is another injury to the knee. With a shattered patella, this is a comminuted fracture. Remember, a comminuted fracture is when a bone breaks into 3 or more pieces. And you can see some different types here, different ways that the patella can break or fracture and fragment into many smaller pieces. You can see how they've wired the patella back together there. Next thing we'll talk about is patellar tendonitis. Patellar tendonitis is also known as jumper's knee. People that jump, athletes where there's a lot of jumping, like volleyball, basketball, a lot of jumping and landing. Patellar tendonitis or jumper's knee is something that is common. With patellar tendonitis, there's anterior knee pain, which is just below the patella, and it's over the patellar tendon. The treatment for patellar tendonitis is going to be activity modification. The athletic trainer may ground that athlete, so they're a volleyball player, instead of jumping, 250 times during practice, they're grounded, so they're not jumping, they're not leaving and having that impact at all in their knee. They also require non-impact activities such as cycling and swimming for a while to allow the tendon to heal. Next one is fat pad syndrome, and if I move here so you can see, the fat pad is right here. You see the patellar tendon here, and the fat pad is right in there. For a picture of where that is located at. Inflammation of the fatty tissue lying deep to the patellar tendon. So deep is under or behind, deeper towards the middle, superficial towards the skin layer. laying deep to the patellar tendon, often confused with patellar tendonitis because they are in the same place. The fat pad is just under it or deeper to it, so that you can see how that would be confusing. If somebody is in an occupation where they spend a lot of time on their knees, for example, a plumber or somebody that's constantly that impact on their knee, the fat pad syndrome is going to be more likely. Then an athlete is probably going to be more likely to have jumper's knee or patellar tendonitis. Treatment is going to avoid the rapid movement of extension or kicking. Taping, icing, and anti-inflammatory drugs are the treatment that the athletic trainer or the doctor will most likely recommend. LCL sprain is a lateral collateral ligament. Remember, this is on the outside of the knee, the lateral side of the knee. Stretching or tearing of the LCL, tenderness with palpation or feeling along the outside of the knee joint there. There's going to be pain and laxity with the stress test, which we're going to watch. It's a varus stress test in just a moment. Treatment is going to be protecting the outside of the knee, rest, ice, compression, and elevation. Okay, let's watch an LCL test. It's called the varus stress test.
So this test, we're going to do the varus stress test, and the varus is then to test the integrity of the LCL ligament. Kind of the same hand position as we've done previous with the MCL, but we're just on the other side.
So the pink tape
in this case, the hands
is where the MCL would lie.
On the medial aspect of the knee, and we're going to go ahead and produce a force that's going to go perpendicular to the knee joint, going from inside medial to outside lateral. Other hand is down here at the ankle, and we're just going to go ahead and bend that knee up to
They're looking for gapping right here.
Degrees of flexion, and then we're just going to apply that force, and you'll see that open up.
You can see gapping there.
A kind of a note to make is the LCL is not part of the joint capsule like the MCL is, and so you can get a little bit more movement when you do this test. Just remember to always compare to your other side and make sure you get a good history with your athletes so you know what's going on with both knees. So again, that is just putting that hand on the medial side, and we're going to do that perpendicular force across the joint that way, okay? Lift up. And really, if the hand placement, if you think about it, it's between the joint lines, so between the femur and the tibia. So.
And we're going to move on. MCL, this is medial collateral ligament. Remember, we talked about that. We talked about O'Donoghue's terrible triad, and we already watched the valgus stress test for MCL tear. We'll move on to PCL tear. PCL tear is posterior cruciate ligament. So remember the ACL and the PCL, they kind of cross in the knee. This is a less common than the ACL tears. It can result from a fall on a flexed knee with the foot plantar flex resulting in the tibia striking the ground first and then being pushed back. The two tests are the SAG test and the posterior drawer test. The tibial tuberosity falls posterior to that, the SAG test. And treatment, protection, rest, ice, compression, and elevation, assessment by a physician if it's completely torn. Okay, so we'll watch the posterior drawer test first. Remember, the ACL is anterior drawer test, PCL is posterior drawer test, and we're going to start about here.
We don't want to just jump on their foot because it gives them a fright. So sit on your foot, and what I'm going to do is pull first anteriorly and then posteriorly. So anteriorly, solid endpoint, no laxity there. Posterior drawer, looking at the PCL, very solid, no laxity, no pain. If we
so
think
we're going to watch this one for a positive SAG test. We'll make this a little larger.
Hi, my name is Kurt Stevenson, Assistant Athletic Therapist at St. Mary's University. We're going to go over a posterior SAG test for the knee. If it's positive for PCL, torn PCL. So comparing both knees with the athlete lying in supine, knees fully straight. I'm going to get you to bend your right knee up. You can see how it looks like a normal knee. We bend the other one up. And what you can see is how the entire tib-fib complex has shifted posteriorly. So
that's a positive SAG test.
Positive SAG test.
Just review ACL. There was 3 tests we talked about with the ACL: the Lockman test, the anterior drawer test, or the 2 slide test, and then there's also a pivot shift test. Next injury is epiphyseal growth plate. This is an injury that occurs among immature athletes, and we've talked about growth plate fractures before in class. Next is Osgood-Schlatter's. Osgood-Schlatter's symptoms involve the tibia, the tubercle of the tibia, which is on the front. I think on the next slide there's a picture right here, and then there's going to be a lump there, and bony surface is going to start to grow. Mostly affects males ages 12 to 16 and females ages 10 to 14. So when there's a time of rapid growth during adolescence is when this Osgood-Schlatter's often happens. Happens when the skeletal system grows faster than the muscular system. There's going to be pain, weakness of the quads. There's going to be swelling with activity, a visible lump on the front that you can palpate on the tibial tuberosity there. The treatment is going to be protective pad, ice, anti-inflammatories, and physician referral, for some. Once again, here's a picture of what Osgood-Schlatter would look like. IT band syndrome, or iliotibial band syndrome. It's inflammation that occurs on the thick band of fibrous tissue that runs down the outside of the leg. It goes over the hip joint, and it also goes over the knee joint. So you might have IT band pain at the hip, or you might have IT band pain at the knee. And I'll move my screen so you can see the IT band, this fascia that runs along the outside of the hip and on the outside of the knee there. Treatment analysis of your gait, and how runners get IT band syndrome oftentimes. So in analyzing what the gait looks like, putting orthotics or making pieces that go into the shoe, having proper footwear, making sure you're not putting too many miles on your shoe, ice, stretch, foam rolling is another thing, and reduced activity is going to be another treatment. Dislocation of the knee and or fracture here. With dislocating the knee, this is different than dislocating the patella. Remember, the patella is a sesamoid bone that rides on the trochlear groove of the femur. Dislocating of the knee is dislocating the femur from the tibia. So result of high energy direct trauma, a fracture of the patella can occur when the knee strikes. The distal-femoral proximal tibia fracture. So we can fracture the femur, we can fracture the tibia whenever this impacts. So it's high impact. And we're going to start with osteoarthritis of the knee or degenerative joint disease. We will do that tomorrow. Have a great day. Don't forget to take your quiz.